Presentation and evaluation of the advanced disease. The most common presenting symptom of ovarian cancer is the decreasing order of frequency. Most common is abdominal swelling, abdominal pain, dyspepsia, urinary frequency, weight change. Unfortunately, the presence of any of these symptoms often are indicative of an advanced disease, and although there are no reliable constellation of symptoms indicative of early disease, patient advocacy efforts urge women to listen for the whisper. Certainly, a high index of suspicion on the part of the physician can sometimes lead to early intervention in any woman between age 40 to 70 years who had persistent gastrointestinal symptoms. The problem, of course, is the most non-specific abdominal and pelvic complaint. They are not malignant, and it is not cost effective to order CT scan for every woman with a presumptive diagnosis of irritable bowel syndrome. So in addition to the abdominal bloating resulting from the malignant ascites, many women with an ovarian carcinoma will experience significant gastrointestinal disturbance and may present with the signs and symptoms of small bowel obstruction, and others may present with an unexplained or uninterrupted weight loss due to a decreased oral intake as a result of the intra-abdominal pressure on the stomach and intestinal tract, and obstructive symptoms making it hard to keep the meals down. So loss of appetite is common in these cases, and finally some patients will present with shortness of breath due to malignant pleural effusion, whereas others have a diagnosis of the carcinoma made simultaneously with the occurrence of the thromboembolic events. And the eminent German physician Rudolf Virchow proposed the triad of hypercoagulability and stasis of the turbulence of blood flow, endothelial injury. Triad of hypercoagulability, stasis or turbulence of blood flow, and endothelial injury, and all of which are associated with the malignancy, to elucidate the etiology of the pulmonary embolism. Decisions to explore a patient with a carcinomatosis likely to have arisen from the adnexia can be made only by the gynecological oncologist, and a methodological assessment of the preoperative nutritional and performance status of the patient is imperative. Preoperative serum albumin, pre-albumin, they should be obtained along with a complete blood count, metabolic panels, coagulation panel, liver function, blood type, screen for antibodies, CA125, urine analysis, culture. MDT collaboration is incumbent throughout pre-operative medical optimization to the gynae onco working directly with the patient's primary care physician and other subspecialist physician like cardiologists are needed, and personalized review of all these films with the radiologist can be helpful, and multiple parenchymal liver mats, extensive suprarenal adenopathy, podahepatic disease, bony mats, pulmonary mats, and any other extra abdominal mats, they are relative contraindications to the primary cytoreduction. Such patients should be treated with a neoadjuvant chemotherapy followed by interval cytoreduction if there is radiologic, biochemical, or physical evidence of objective response. And once a decision to proceed with the surgery has been made, it is necessary to first correct malnutrition, anemia, coagulopathy, and electrolyte abnormalities. Urinary tract infection that should be treated if present, and preoperative thoracentesis to address a pleural effusion. IVC filter placement for any patients who present with the thrombosis may also be required. And clinical which is unclear, combined with the PET or CT, even for diagnostic laparoscopy may be used to determine whether there is any possible surgically resectable gross disease while minimizing the perioperative morbidity because of the risk of inadvertent trocar injury to the bowel. Tumor seeding along the port tract and laparoscopy should be considered in the setting of widespread carcinomatosis and large volume malignant sites as a core biopsy, and neoadjuvant chemotherapy is popular. Though many clinicians believe that every patient who does not clearly have stage 4 disease deserves laparoscopic evaluation for resectability. Occasionally, intra-abdominal TB, yersinia, and pseudomyxoma peritoni from a ruptured appendiceal neoplasm will be included in the differential diagnosis. Now we will see the staging. Staging, FIGO staging. So stage 1A is tumor confined to one ovary or tubes or capsule intake and no tumor on the ovarian surface, no malignant cells in the ascites or peritoneal cytology. 1B tumor involves both the ovaries or tubes, capsule intake, no tumor on the ovarian or tubal surface, no malignant ascites or peritoneal cytology. C1, C2, C3, C1 is capsule rupture intraoperatively. 2C2 capsule rupture preoperatively on 1C2 capsule rupture preoperatively on ovarian tubal surface, and 1C3 malignant ascites or peritoneal cytology. 2 is tumor in the pelvic, involvement of the primary peritoneal carcinoma. 2A extension and or implant of uterus and or fallopian tubes. Then 2B is extension to other pelvic intra-abdominal tissue. Then 3 is 3A1. 3 is tumor of one or both ovaries and tubes with primary peritoneal carcinoma with cytologically or histologically verified peritoneal metastasis outside the pelvis or retroperitoneal lymph nodes. So 3A1 is positive retroperitoneal lymph nodes only, verified cytologically or histologically. 3A11 metastasis maximum of diameter 10 mm. 3A12 is metastasis maximum diameter of 10 mm, more than 10 mm. 3A2 is microscopically extrapelvic peritoneal mats with or without positive retroperitoneal nodes. 3B is macroscopically peritoneal pelvic mats of up to 2 cm with or without retroperitoneal lymph node mats, including the capsule of the liver spleen but excluding parenchymatous metastasis. 3C is macroscopic extrapelvic peritoneal mats larger than 2 cm with or without retroperitoneal lymph node mats, including capsule of the liver spleen but excluding the parenchymal metastasis. And 4 is distant mats excluding the peritoneal mats, and 4A is pleural effusion with positive cytology, and 4B is parenchymatous metastasis and metastasis to the extra-abdominal organs like inguinal lymph nodes mats and extra-abdominal lymph node mats.